Thank you. So, welcome everyone. Today is our second presentation for our 2026 ARCA Virtual Learning Institute. We're glad you're here. Throughout the entire month of May, ARCA will be hosting a series of presentations focused on disability content and content to support rehabilitation counselors, students, and educators. Today, our presentation is Applied Rehabilitation Counseling, Multi-Setting Approach. And I would like to take a moment to thank Dr. Stapleton for being here to share her expertise with us today. Dr. Stapleton is a native of North Florida and currently serves as chair of the Department of Rehabilitation Studies at Alabama State University. She also coordinates an online Master's of Science in Rehabilitation Counseling program. She's a CRC, an NCC, a licensed professional counselor, supervisor, and a board-certified telemental health provider. She brings more than 30 years of professional experience across diverse rehabilitation settings, which include, but certainly is not limited to, corrections, forensic rehabilitation, inpatient, outpatient substance use treatment centers, adoption, and foster care services. In addition, she has provided mental health services to older adults in skilled nursing facilities. We're so excited that you're here with us, Dr. Stapleton. And I just want to remind our attendees that we ask that you keep your microphones muted, put questions in the chat, and at the end of our session today, Dr. Stapleton will answer those questions. With that being said, Dr. Stapleton, the floor is yours.
Hey, well, good afternoon, and thank you for this opportunity to discuss this topic. The topic is applied rehabilitation counseling strategies, and we'll be looking at evidence and practice-based approaches across multi-settings, which will include diverse disciplines as well. So we have a few learning objectives. The first three are just basically, I think, designed to enhance and further your understanding and appreciation of a few items, mainly applying counseling theories, evidence-based practices, and vocational frameworks to support the work that we do with people with disabilities. Utilizing assistive digital and telehealth technologies to improve access, engagement, and client outcomes. Collaborating effectively within interpersonal professional teams to enhance coordinated and person-centered service delivery. And then that last objective there is perhaps the most important one, implementing strategies that promote employment, independent living, community participation, and overall quality of life for people with disabilities. And that fourth bullet is basically, that's the end game. That is that's our priority, is promoting those life situations and circumstances. So we'll talk about the roles and functions of the rehabilitation counselor. The role is multifaceted. It includes, at its core, assessor, plan developer, counselor, advocate, case manager, and consultant. These roles require coordinated, person-centered services that are aimed at facilitating competitive, integrated employment and independent living outcomes. And that term person-centered is going to pop up quite a bit in this presentation. The practice of rehabilitation counseling is guided by ethical principles that align with the CRCC Code of Ethics and the RSA priorities. And so what I have here, this first figure, it depicts the what I'm referring to as the modern vocational rehabilitation process. It outlines 9 phases. These are integrated phases. And these spaces are underscored by person-centered planning, collaboration with family and advocates, community and partner agencies, culturally responsive services, and equity and access for all individuals. And so this VR process is a dynamic, cyclical, and outcomes-driven process that again integrates individualized services, evidence-based practices, and systems supports to provide equitable access to competitive, integrated employment and independent living for people with disabilities. So I know this is kind of a busy figure, but I wanted to kind of capture some of the things that I'll be talking about. So just briefly, I mentioned that the practice of rehabilitation counseling aligns with CRCC priorities. And those of you who are clinical mental health professionals and social workers, those of you who are in the audience will agree that these priorities also align with your practice. Just touching on some of these, of course, ethics in professional practice, credentialing excellence and standards, research and evidence-based practice, integration of technology and telehealth. Those are some of the CRCC priorities that the work that we do as rehab counselors aligns with. I just also want to touch on the RSA priorities: competitive integrated employment, workforce development and talent pipelines, transition services for youth and students with disabilities, rural and underserved communities. And again, I'll mention assistive technology and innovation. So those are some RSA priorities that guide our work. Disabilities that come in many forms. It's a natural part of human diversity. Inclusion benefits everyone. So people with disabilities are served in many practice settings and many service contexts. And so I just wanted to create a slide that would indicate that. And of course, this isn't an all-inclusive slide, but it does highlight some of the practice settings and service contexts. Some of you may say, well, my setting's not on here. And that may be something that you may want to add in the chat for later discussion. So as you can see there's a lot of diversity here when it comes to practice settings. Okay, so in these practice settings, we have several disciplines, right? And so this slide speaks to some of the common aspects of service delivery across disciplines in these settings, right? And so although rehab counselors, clinical mental health professionals, and clinical social workers have distinct training areas and roles, they frequently collaborate and provide overlapping services, particularly for people with disabilities, mental health conditions, chronic illnesses, and social challenges. I know here in Alabama, our state VR department, they're hiring clinical mental health workers and licensed social workers to provide, traditional rehab counseling services. So it's very important that those who maybe didn't traditionally serve people with disabilities, it's very important that they have an understanding of what they can bring to the table. So there are some common aspects across the disciplines. Person-centered practice, again, that's mentioned, case management and care coordination, crisis intervention and support, goal planning and outcome monitoring, use of technology and telehealth, focusing on empowerment and independence, ethical and legal practice, cultural competence and humility, advocacy, interprofessional collaboration, assessment and evaluation, counseling and therapeutic interventions. And so when these disciplines, when they work together or they work, singularly on behalf of people with disabilities, they all have a shared goal. And that goal is to support the well-being, the functioning, and the quality of life of individuals with disabilities. Okay, so we're going to kind of pivot a little bit and we're going to talk about a disability model that promotes employment and independent living. And there's a lot of disability models out there. I chose to discuss a very fundamental core model that I feel is a very good information gathering model. It's a good assessment model, and it's also a good model that can be used to monitor outcomes. And most of you, if not all of you, should be familiar with the biopsychosocial model, which integrates the medical and social perspectives by recognizing disability is not solely a function of impairment, nor entirely a product of societal barriers. Instead, it arises from the dynamic interplay among biological conditions, psychological processes, and social environments. This biopsychosocial framework can be used to improve client outcomes across diverse populations and service environments. This is a very holistic perspective, and it is especially critical in underserved communities where social determinants of health, such as poverty, stigma, and limited infrastructure, plays a significant role in shaping outcomes. So this is just a glance of the model, an at-a-glance model. And there are several dimensions to this model. For the sake of time and space, I chose to highlight intervention strategies, goals of interventions, strength of the model, and the role of the client. And you could examine all of those dimensions through the biological lens, the psychosocial lens, the social factors lens. And this is kind of what that looks like. I'll give you just a little time to take a look at it. Um, kind of walk you through an example. When it relates to the role of the client dimension through that biological lens, the client role is to manage health condition and to participate in treatment. When we look through that psychosocial lens as it relates to the role of the client, the role is to develop insight, coping skills, and adaptive behaviors. And then when we look at the role of the client through the social factors lens, the role is to engage with and navigate social systems and supports. If we'll do one more, the goal of interventions through that biological lens is to improve physical functioning and health outcomes. Through the psychosocial lens is to enhance psychological well-being and adaptive functioning. And then that social lens, if we look at interventions through that social lens, the goal is to promote inclusion, access, participation, and quality of life. So it's a fairly simple model. So the biopsychosocial factors are important in working with people with disabilities because they can influence mental and physical health, adjustment to disability or illness, employment opportunities, independent living, access to treatment and support services, and quality of life and community participation. And I mentioned before, I think this model is not just a good information gathering framework, but it's also a good assessment and outcomes monitoring framework. Okay. And of course, regardless of your discipline, this is a really good model to use when working with people with disabilities. At this time, we're going to look at some vocational frameworks, two in particular, that promote employment and independent living. Again, that's our end game. First, we'll talk about the individual placement and support framework, referred to as IPS. And then we'll talk about the social cognitive career theory framework, SCCT. With the IPS framework, there is an emphasis on job placement, employer engagement and retention supports. There is a focus on rapid placement in competitive integrated employment. Uh, there is a focus on placing, then training. And this approach is successful with anyone who is eligible for work. Any person with a disability who has reached that phase in the rehab process where they're eligible for work and they want to work. With the SCCT vocational framework, there's a focus on career development and decision making. career interests, choice, and performance. There's also an emphasis on self-efficacy, outcome expectations, and goals. This framework addresses environmental supports and barriers, and it supports confidence building and informed choice. Both of these frameworks can be integrated with the VR process as well as with behavioral health services. Let's take a look at the application across the vocational rehabilitation process. We're looking at integrating the IPS and the SCCT frameworks for optimal outcomes. During the early stages of the VR process, doing intake assessment and IPE development, the SCC framework is a primary focus. At that time, we were focusing on building self-efficacy and career confidence. We're exploring interests, values, and goals. We're identifying barriers of sorts, and we're supporting informed choice in developing the IPE, or individualized plan for employment. During the latter stages of the VR process, where the focus is on job placement, employment, and follow-up services, we see the IPS becoming more in focus, more in use, being of greater benefit. Again, focus on rapid job search aligned with client preferences. There's direct employment engagement. There's on-the-job training and supports. There's ongoing follow-along services for retention and advancement. And so one of the things that the research indicated is that with the IPS framework, it addresses a lot of external factors, such as employment access, supports, and systems, whereas the SCCT vocational framework addresses more internal factors such as motivation, beliefs, and decision making. Together, these frameworks promote sustained, competitive, integrated employment and career growth. So these frameworks are important not just for the rehabilitation counselor, but it's also these frameworks, or having an understanding of these frameworks, are important for our clinical mental health professionals and our licensed social workers. So the dual focus here is particularly valuable in environments where clients have experienced prolonged unemployment or limited exposure to career pathways. So we're trying to talk about, I mentioned in my slide presentation, my cover page, we're talking about practice-based and evidence-based, evidence-informed practices. And that's one of the reasons I shared with you information about the biopsychosocial model of disability. I shared with you the two vocational frameworks, and I wanted to talk a little bit about a trauma-informed practice because trauma is the buzzword in the helping profession. And I think it's a really good overlay of the biopsychosocial model, as well as I think it's a really, really good assessment model as well. So what are some key principles of trauma-informed practice? Well, those principles include safety, trustworthiness, and transparency, peer support and collaboration, choice, empowerment, and voice, and cultural, historical, and disability humility. These principles are applied within a person-centered framework, there's that word again, to promote healing, reduce re-traumatization, and support inclusion and well-being. Trauma histories are common among people with disabilities. Trauma-informed and trauma-sensitive counselors are better equipped to support client adjustment, recovery, and employment outcomes. And so professional counselors must understand trauma types and their effects and best practices for supporting trauma survivors. They must recognize trauma-related risk and symptoms that may interfere with life goals. They must assess for trauma exposure and communicate carefully and sensitively with families and clients. And so it's a good practice, I think, to have a few reliable trauma assessments in your toolbox. people with disabilities may experience trauma before disability, during the onset of disability, or because of disability-related experiences. And so I think it's very good to know that the trauma may be experienced before the disability, during the onset of disability, or because of disability-related experiences. So here's a visual of what some of this might look like. Um, Area of trauma, trauma leading to disability. For example, might be a motor vehicle accident, a workplace injury, combat injuries, and the impact uh, could be PTSD, of course, grief adjustment difficulties, depression, anxiety, and so on. Medical trauma. Some of our clients may have had repeated surgeries, invasive procedures, chronic hospitalizations, and those things can have an impact. Fear of healthcare settings, anxiety, mistrust, re-traumatization. Okay, so I guess you can see why it's important to be able to assess for trauma, to have some understanding of the impact of trauma. Abuse, neglect, and exploitation. We know people with disabilities are at a higher risk of abuse, neglect, and exploitation. And so physical abuse, sexual abuse, caregiver neglect, things like that can impact the individual's, uh, their progress, their recovery, their participation in services, the outcome of services. Then we have bullying and social exclusion. Okay, these things can bring about trauma for our clients, discrimination and ableism, employment discrimination, inaccessible environments, denial of accommodations. Okay, these things can result in chronic stress, hopelessness, diminished quality of life. And then, of course, there's institutional or systemic trauma. Okay, examples could be seclusion, restraint, lack of accessibility, exclusion from decision making. And the impact again could be mistrust of systems, you may have emotional trauma, fear, re-traumatization, and then lastly, trauma related to chronic illness or pain. Okay, so it's just an example of areas of trauma and their potential impact on our clients. Here's just a visual of what we went over. The client, the person is centered in the center of this figure, and then we have those um, trauma-informed principles that we just went over. And again, the goal of trauma-informed practice is healing, empowerment, and equity, reduce re-traumatization, and promoting inclusion and well-being. Because trauma can be very isolating. I'm gonna pivot again, and I wanted to touch base on, you know, there's so many of us trying to do the same work or similar work. Whether we are a rehab counselor, clinical mental health professional, clinical social worker, there are certain competencies that are important. Now this is not something you don't know, but I thought it would be worthwhile to mention. And so there are certain core competencies that all helping professionals must demonstrate. And what underscores these, what I'm calling competencies that cut across disciplines, what underscores that is the central concept of holistic and person-centered practice. So what are some of these cost-cutting professional competencies? Client-centered practice, collaborative engagement, cultural and contextual responsiveness, ethical practice, goal-oriented intervention, adaptability, and flexibility. And so for me, this is like, when I read this list, I visualize a checklist that I'm going to keep at my side throughout my career, throughout my years of practice. And from time to time, I'm going to assess where I am as it relates to these competencies. Where do I need to grow? Where do I need to focus more? where should my focus be? Where should I increase my work and my efforts? So I think this makes for a really good checklist, um, a competency checklist. And so, as professional counselors, we all have our go-to theoretical orientation or counseling approach or counseling therapy. I wanted to highlight three complementary counseling approaches that can be used with people with disabilities: motivational interviewing, cognitive behavioral therapy, solution-focused brief therapy. In settings such as community mental health centers, correctional programs, or rural VR agencies, counselors can use motivational interviewing, or MI, to enhance engagement. They can use CBT to address cognitive and emotional barriers, and they can use solution-focused strategies to build momentum toward employment and independent living goals. These complementary counseling approaches, they promote flexibility that ensures responsiveness to diverse client needs and service contexts. And we're going to look at those in a little bit more detail. So these counseling approaches are complementary, but they're also developmental in nature. And we'll talk a little bit about those. I do have a brief case study. This is Marcus, a 42-year-old male with a spinal cord injury following a workplace accident. He uses a wheelchair, previously employed in construction, and he has been unemployed since his injury. He reports low motivation to return to work. He experiences symptoms of depression and decreased self-worth, expresses uncertainty about job capabilities and fear of failure, and he is limitedly engaged in vocational rehabilitation services. His engagement is low as it relates to that VR process. So what does this look like? I mentioned that these approaches can be complementary and developmental. What does this look like in practice? Um, so we're thinking about the helping relationship. During the early part of that relationship, phase one, motivational interviewing, again, which is about enhancing readiness for change. Um, the helping professional could utilize motivational interviewing to address ambivalence about returning to work and engaging in rehabilitation services. The counselor could focus the session on open-ended questions, applying reflective listening to validate concerns, exploring values and discrepancies, eliciting change talk related to independence and financial stability. The outcome would be that Marcus begins to express a willingness to explore employment options and agrees to participate more actively in services. So MI is used to kind of hook Marcus to get him to buy in to what is being offered and what could be. So let's look at phase two of that helping relationship. Okay, kind of the middle phase perhaps. Uh, Cognitive behavioral therapy uh, techniques could be utilized to address thoughts and emotional barriers. Um, the focus is on reducing depressive symptoms and challenging maladaptive beliefs related to disability and work. The counselor identifies negative automatic thoughts, uses cognitive restructuring to challenge beliefs, introduces behavioral activation, builds self-efficacy through small, achievable goals. And what's the outcome? For Marcus, he develops more balanced thinking, such as, I may need a different type of job, but I still have skills to offer. His mood improves, and he demonstrates increased confidence in his abilities. Okay, so we talked about MI, the use of MI, the use of CBT. Let's talk about solution-focused brief therapy, phase three of that helping relationship. Um, Solution-focused therapy is about building goals and moving forward. And so with this approach, the counselor assists markers in identifying strengths, setting goals, and supporting him to move forward towards employment. The counselor might use miracle questions, may use scaling questions, um, may assist Marcus in identifying exceptions. Counselor may highlight transferable skills from previous work. Okay, and the outcome, Marcus identifies a goal of pursuing a remote customer service job. And he also enrolls in a short-term computer skills program. He reports increased hope and direction. So what does this look like? Okay, an integration of these approaches, this is how it looks. Through the combined use of MI, CBT, and CFBT, Marcus progresses from ambivalence to engagement to action. He demonstrates improved mental health and self-efficacy. He actively participates in the vocational rehabilitation planning and services process. And he secures part-time employment within 4 to 6 months. And so that's a successful outcome. All right. We're going to talk a little bit about technologies. I think in my abstract I mentioned assistive technologies and telehealth technologies. So we're going to talk a little bit about this. A few weeks ago, one of my colleagues, Dr. Angela Hall, did a presentation on assistive technology, and she focused in on remote work and how it's such a good example of the utilization of various assistive technologies. And so kind of pulled some things from her presentation because I just found it very, very interesting. So hopefully you will too. I'll start out by giving you a definition of assistive technology. It's broadly defined as any tool, system, or strategy that enhances functional capabilities. Assistive technology serves as a mechanism that enables individuals to perform essential job functions without being constrained by physical or environmental limitations. And so this kind of leads me into the discussion of remote work. And we just by coincidence, actually, this followed Marcus, you know, securing remote work. But it worked out perfectly because I'm going to focus the discussion of assistive technology on remote work. For rehab counselors, clinical mental health counselors, social workers, and related professionals, understanding remote work as an assistive technology strategy is important for promoting vocational inclusion, accessibility, and equitable workforce participation. So what are some key aspects of remote work from an assistive technology perspective? When it comes to technology and accommodations, it's important to ensure accessibility of remote platforms, to educate clients on using accessibility features and productivity tools, to use collaboration tools that are screen reader compatible and keyboard navigable. Okay, and so the rehab counselor and the helping professional has a role in making certain that these things are in place. It's important that as professional counselors that we assist clients, sorry, but businesses and employers in understanding the importance of utilizing screen readers, speech-to-text software, captioning services, adaptive keyboards, ergonomic devices, hearing assistive technologies, and so on and so forth, because these accommodations are necessary for effective remote work. Employment engagement and advocacy. We have a role in promoting remote work as a reasonable accommodation. We have an obligation to promote work as a reasonable accommodation, not a special privilege. We can assist with job carving or redesign, to support remote compatible roles. We can address employer concerns related to productivity, supervision, and communication. So we do have an obligation to work through any employer concerns. Retention and ongoing support. Monitoring adjustment and performance during early employment. That's important. We have an obligation and a role there. We can be of assistance to the employer. Supporting problem solving. That's related to working in isolation, workload, uh, or communication issues. We have a role in encouraging the use of structured routines and wellness strategies, providing ongoing follow-up and reassessment of accommodations as needs change. Just a little bit more about remote work. I found this very, very interesting, actually, so I hope you did too. We can assist the employer in creating a flexible design, allowing for flexible scheduling, to support energy levels, medical needs, and caregiving, supporting asynchronous work rather than real-time availability when possible, focusing on outcomes and deliverables and not hours, not just hours or webcam use. Inclusive communication practices are important, and this can be promoted by a really good skill use of assistive technology. We want to make certain that, to the extent possible, that live captions are enabled, that there are transcripts or chat options for meetings, that there are multiple communication formats, that any new software before being adopted is vetted appropriately. There should be shared agendas that are clear. There should be written summaries or follow-ups. There should be the avoidance of reliance on informal or visual only communication. There should be the normalization. We should push for the normalization of the use of captions and chats and accessibility features for everyone. And we want to train teams on accessible virtual communication norms. Lastly, on this particular slide, I'll speak to equity and advancement. We want to make sure that remote workers are considered for promotion and leadership roles. We want to promote equitable access to training, professional development, and networking. We want to track outcomes to identify potential remote work biases, and we want to create make certain that there's a transparent criteria for the performance, for work performance and advancement. Many individuals with disabilities face challenges related to transportation, mobility, fatigue, or inaccessible public spaces. Remote work, assistive technologies minimizes these barriers. Virtual work expands access to jobs for individuals in rural or underserved areas and for those who may encounter workplace accessibility issues. Okay, so that's my little spiel on assistive technology, viewing it through the remote work lens. Just briefly, we'll talk about telehealth technologies. This is just hopefully refresher information. Those of us who are providing services by way of telehealth, we want to make certain that we do so ethically, right? For those of you who are CRCs, the CRCC Code of Ethics directly addresses telehealth under Section K, technology, social media, and virtual counseling. The American Counseling Association, to the best of my knowledge, I think they're in the midst of rolling out a new edition of the Code of Ethics, but the 2014 edition addresses telehealth under Section H, distance counseling, technology, and social media. The National Association of Social Workers, their Code of Ethics, in the 2021 update, I kind of went through it really quickly. I didn't see anything that speaks directly to telehealth, but of course, sections 1.04, competence, section 1.07, privacy and confidentiality, provides a really good framework for practicing via telehealth. So we'll speak a little bit about equity and access. Focusing on equity and access ensures that clients, regardless of disability, income, location, language, or technological literacy, that everyone can meaningfully participate in and benefit from remote services. The use of telehealth can reproduce or deepen disparities if equity and access issues are not intentionally addressed. From an equity perspective, counselors must recognize that clients have unequal access to devices. They have unequal access to reliable internet, private spaces, and digital skills training. For some individuals with disabilities, telehealth is highly enabling. For others, it may introduce new barriers. So you have to be very, very intentional in your assessment of whether or not this is the right service delivery format for the client. It has to be appropriate for the client, not just convenient for the service provider. A commitment to equity requires counselors to assess each client's circumstances and provide tailored supports, such as flexible scheduling, asynchronous options, simplified platforms, or coordination with community partners to provide internet or device access or assistance. So equity and access is very, very important. So in a nutshell, when we talk about assistive technologies and telehealth technologies, it's important to remember that they can significantly enhance service delivery by reducing long-standing structural barriers to care. In rural areas, in particular, people with disabilities often encounter transportation challenges, provider shortages, and limited access to specialized services. So these are really good technologies. But there's a vital assessment piece that's attached to this. All right, we're on the downside of this. I don't know how well I'm doing on time, but I had mentioned that I would talk a little bit about interprofessional collaboration. And so we're going to finish up with a kind of a discussion of that. We mentioned earlier, very early on, about shared collaborative roles and some core competencies and things of that nature. This table kind of speaks to collaborative roles in supporting people with disabilities. And again, this whole process of working together is underscored by a person-centered approach, holistic assessment and understanding, interdisciplinary collaboration, resource connection and coordination, culturally responsive practices, ethical practices and confidentiality, and empowerment and strength. By integrating unique expertise and working together, rehabilitation counselors, clinical mental health professionals, and social workers create a strong, coordinated support system that promotes mental health, independence, inclusion, and meaningful participation for people with disabilities. I remember a time when you thought of social workers, what came to mind was the case management role predominantly, and the advocacy and social justice role. Um, and that was kind of the perception of roles for a long time. With the clinical mental health professional, the mental health role was always that the one that was most obvious, or the one that people would kind of think of when they heard mention of a clinical mental health professional. But times have changed, they're changing. We see clinical mental health professionals more and more engaging in case management roles. Of course, the career and vocational piece was there to some extent, but we see a lot of advocacy and social justice initiatives being engaged in. And the rehab counselor, folks thought of career and vocational role. That was like, and of course the advocacy and social justice roles. But over time, you know, the roles are merging. And I think that it's very important to embrace that and be respectful of that. And so this slide just talks a little bit about the core roles of the professionals and then what those tasks, kind of look like. So just a little bit of hopefully useful information. And advocacy may look a little different through the lens of the rehab counselor. Uh, Case management may look a little different, but all of these services, all of this work is important. It should be respected. It should be valued. And all of that is what interprofessional teamwork is about. The World Health Organization defines interprofessional collaborative practices as multiple health workers from different professional backgrounds working together with clients, families, caregivers, and communities to deliver the highest quality of care. And that's what it's about, delivering the highest quality of care. And I think the good thing about interprofessionalism is that, no solo person can meet the needs of a person in need. Interprofessional collaboration is critical for improving client outcomes in underserved and rural communities. Coordinated care among professional counselors, allied and healthcare providers, and educators reduces fragmentation and maximizes resource utilization. By practicing discipline humility, I like that word, maintaining transparent communication, and engaging in shared decision making, counseling professionals, regardless of their discipline, can deliver more comprehensive and culturally responsive care. Interprofessional collaboration fosters a care delivery context where various helping professionals can cooperatively exchange knowledge for the better of their clients. And sometimes, we are reluctant to consult, to confer, to reach out and ask questions of members of the interprofessional team, but that should be encouraged. That should be the norm. Benefits of interprofessional teaming and integrated teams: fewer hospital readmissions, fewer out-of-home placements or admissions to more restrictive levels of care, improved client outcomes due to better informed decision-making and more accurate, holistic client assessments. Everybody brings their observations and their skill levels and expertise to the table. That makes for a really good holistic client assessment. Another benefit is better information exchange, follow-up services, and communication due to expanding practice out of the silo. Interprofessional team members must be willing to commit to familiarizing themselves with the scope of practice and ethical codes and obligations of other disciplines and care team members. They must be willing to commit to resolving differences in opinions and perspectives expediently, right? And in the best interest of the client. They must also be willing to acknowledge barriers to interprofessionalism, power and status conflicts, unjust stereotypes, and interprofessional mistrust. All right. I got through all of the information. I know it was a lot of information. Thank you for your attention. Questions, comments, observations?
Ah, Dr. Stapleton, thank you so much. We do have a few questions in the chat. The first one is, have you noticed that framing remote work as the specific accommodation of assistive technology has changed their attitude toward remote work? Some employers do not consider remote work as a reasonable accommodation and instead feel it goes against policy or essential functions of the job.
Mhm. Yeah. So your question is whether or not do I see that changing over time, where there are more employers who are seeing it as a reasonable accommodation, or that was a long question. I'm sorry.
That's fine. And Dana, if you'd like to unmute and clarify.
Yeah,
I'm
I guess I was thinking about the framing it that way.
Mhm. Yeah. I think with COVID-19, everybody, not everybody, but it became a norm for people, for all people, right? And not just people with disabilities. But I think that there's enough legislation, there's enough uh, positive outcomes to support that. But I think more than anything, there's rehab counselors and other counselors who are advocating for people to find jobs and be integrated into the workforce, that we have to do, like we always do, lots of education. I think we have to be knowledgeable about incentives, and we have to have the law on our sides. And so I think that a lot of that is just educating. I think, Dana, a lot of it's just going to be educating, somehow getting them to buy in to the fact that this individual can contribute significantly with the right assistive technologies, and that you're going to be there to support them throughout the process. You're going to be there to troubleshoot with them. Um, at the end of this presentation, I think there's at least 4 or 5 references that might be helpful, that speaks to ADA accommodations and kind of some legal advocacy pieces to this. Um, so I don't know if I'm answering your question, but I think a lot of it, I think that it is, I don't know what's a good word, that it's not considered as something that is really, really needed. It's just like anybody can do remote work. Why should we give these particular jobs to people maybe with disabilities? Anybody can do, anybody's entitled to it. But I think our spiel and our advocacy has to be pretty much on point and on spot, that this is a reasonable accommodation, that this is a way to enhance your business enterprise. And so I think, again, I think a lot of it is education, advocacy, developing the relationship with the employer, knowing what their needs are, more so than anything. What are the needs of their business, their operation, and really knowing that, and then um, I guess creatively and skillfully coming up with gaps that can be filled by workers with disabilities in their work setting. So I don't know if I answered your question, Dana, but
Yeah, they said, yes, thank you. So I think you did a pretty good job there. The next question is, can you please provide an example of how telehealth can result in the development of a new barrier?
hmm, okay, that's a very good question. I think it would be a new barrier or a significant barrier if we don't do the assessment of a really good assessment of the client. It's not for everybody. It may not be even a preferred uh, mode for some clients. First of all, if the client is not comfortable with telehealth, then we can do what we can to make them more comfortable. But some people may prefer to make the trip in, right? So forcing it can become a barrier. Trying to do it and not having all the technologies in place, not having the person um, familiar with how to use the technologies to their fullest, not having the ability to troubleshoot. I think those things could become barriers. So they have to be well informed. And I think we're obligated ethically to not engage them in telehealth services if they can't use the platform to its fullest. Um, yeah, so that would be my response to that.
Yeah, thank you. And then the next question is, what is a good response if, in reaction to suggesting remote work as an accommodation, an employer says, then everyone else will want to do the remote work too?
Mhm. Well,
How would
that's,
you respond to the employer?
um, well, if we're particularly assisting people with some uh, type of work restriction or limitation. Um, Everybody doesn't have a disability. Everybody is not in need of this type of accommodation to have a purpose in life or to feel like they can contribute. This is a win-win. This could be a win-win for both the employer and the worker. And so I think that response would be, I think it's a good response, but it's also, I think, kind of a cynical, kind of what's a good word for it? To me, it's not a funny response because, of course, everybody could work remotely, but in reality, your business probably could not operate. What we're doing, we're skilled to find people who can help you carry on at your normal level, maybe enhance your level by working remotely. Um, and my concern is not so much everybody. I know this may come across not really nice, but my concern is finding niches for people who, despite their best efforts, there's just too many obstacles to navigating life outside of the home. There's too many obstacles. So what I'm trying to do, my job is not only to help you, but also to help them find a niche. And so I think a long conversation, listening, being respectful, but at the same time communicating that this is my end game. This is what I do. This is what this is all about. If you have other people, I don't know their situation. I can only tell you about my client who's skilled, who's prepared, who's qualified to do this work. And I would like for you to assist me in giving him an opportunity, and I'll be there to support you as the process goes. So I don't know whose question was that. I don't know who asked that question, but um, it's almost like saying I work at a university and okay, if I let one person work virtually, everybody goes somewhere. So that means everybody. That means the custodians. That means physical plant. That means the people in the dining room. That means everybody. I think in reality, most people in most settings could not operate with everybody working at home. And so I think that I think I would have to process that response. Now we know there are some jobs that could be totally remote work, but I don't know. I don't know if I can answer that question. Any better than I did. But I think if it's a facetious question on the part of the employer, I think I would just have to respectfully find some way to say, is that really, I mean, what is really your concern here? I mean, what is really your concern here? Um, and just educating them on the fact that I'm not trying to push someone on you who can't do the job, who can't do the essential functions. I'm trying to make this a win-win for both of us. Who asked that question?
Jennifer, would
Jennifer,
you
did I
like
ask
to add to
your
that?
question, Jennifer? I don't
Yeah,
know.
that answered my question. Thanks.
Yeah, but I can see it being a question that's answered, but my first response would be like, really? Are you being funny?
Yeah.
I'm sorry, but that would be my first response. And then I would have to say, okay, how can I respectfully really get at the heart of his issue? And then,
Well, like I have a relative that works for one of the government agencies that is currently reevaluating and like rescinding everybody's accommodations so
mhm.
that they can reevaluate all of the accommodations. And it's very stressful for some people. So,
Now, I don't want you to think that every client on your caseload who has a disability, we should try and get them a remote work assignment. No, that's not my intent. My
right.
was for us to kind of look at it maybe a little differently
Mm-hmm.
uh, and see it a little differently. I think the more people that we can place, outside of the home setting is great. But in reality, for various reasons, and diverse barriers, remote work is something. It is the way to go, right?
Yeah.
But,
Thank you.
but I think we have to be well educated. I think we have to have our skill, um, well scripted, and I think we have the law and legislation on our side.
Okay. Thank you.
You're welcome.
Well, Dr. Stapleton, we're right at the 2 o'clock mark. Great timing. Appreciate the wealth of information you brought to us today and being part of the Virtual Learning Institute. And thank you to all those who attended today. Really appreciate your attendance. PowerPoint will be made available. We'll have that on our website along with the recording once everything is captioned. So thank you so much and look forward to seeing all of you at our next webinar, which will be tomorrow. Thanks so much. Take care.